Hello, everyone, and welcome to this webinar about perimenopause and menopause, where Carolyn and myself will take you through and give you hopefully some signposts and some tips of how to travel this journey. But before we start, let's actually introduce ourselves. So I'm Dr. Jasmina, and many of you have met me before, be it in Sydney or elsewhere, and some of you have met me online. This is Carolyn that's joining us tonight. Carolyn is a very good friend of mine. She used to work with me as a health coach when I was working in Avalon. She's also trained in functional medicine as a functional medicine health coach. But I will allow Carolyn to tell us a little bit about herself because a lot has happened in her life over the last 2 years.
Yeah, thanks so much, Jasmina, for asking me to join you. And it's really great to be working with you again. I can't tell you how pleased I am. So, yeah, since I left Avalon, I'm still practice nursing, but I'm now in the NHS in the UK. But it's very much part-time, which is great because it allows me to focus on my passion, which you started for me in Avalon when I became, as you said, a functional medicine health coach. So now I have my own practice working with clients via telehealth, just helping them to improve their health via lifestyle change. And in its simplest form, I like to think of health coaching as acting as a bridge between all the health information that's out there for people to hear. So listening to this webinar, for instance, there's going to be lots of ideas about things that people could try. And obviously, when you see patients one-to-one, you'll be recommending a variety of sort of personalized changes, whether that's diet, exercise, sleep, managing stress, etc. And then the difference between what they know and then actually being able to put those ideas into practice in the context of our busy daily lives. And that's not always an easy thing to do. And, understandably, people can often end up feeling really stuck. And as you know, I'm absolutely fascinated by how we make and break habits and how the mind works. And so I've recently completed additional training in cognitive behavioral hypnotherapy. And that actually makes my skill set really quite unique as I'm able to integrate both the physical and mental aspects of lifestyle change, creating a sort of truly holistic approach to patient care, which of course fits really well with your work as a functional medicine doctor. And actually CBT has been shown to help with many perimenopause and menopause symptoms, which is of course the topic of our conversation today and something that my patients often ask me about. So, Jasmina, when perimenopause, menopause, when does it all start? There's kind of a lot of confusion around that.
I know. So you know what? Let's have a look at a timeline because this is probably the easiest way to explain things. In an old concept, women had to be menopausal, and you get your menopause certificate on the day when it's been 12 months since your last period. And at that day, when you get the menopause certificate, you kind of feel like you're able to go and ask for some help. After that day, you are postmenopausal, and that is usually when people started this conversation around, what can be done. So the first thing that I want to challenge today, is that we don't need that certificate. The journey starts a lot earlier as we go through perimenopause. And that perimenopause journey can be, 10 years long. Most women start experiencing it in their 40s when they notice some changes. First of all, they might be having, regular periods, but they're just a little bit different. Maybe the cycle is a little bit shorter. Maybe the period is a little bit heavier. Maybe they're getting a little bit more PMS. Maybe, they're getting some night sweats as a part of that PMS. And then there's kind of a next little bit of a change. So the periods can become a bit more irregular. So the cycle can vary in length, between 3 to 7 days, maybe more. Again, they could be heavier. They can be just like, this is not quite me. There's a bunch of other symptoms they might be experiencing, and I'll touch on that a bit later. And then we're getting to the point of skipped periods. And some of my patients say, well, I haven't had a period for about 6 months, and I thought that I was, getting to be menopausal, and then I got my period. So there is that kind of am I not? stage. And then finally, we get to stages, it's been 12 months since your last period. Congratulations, you're now menopausal. And from that day onwards, later, you are post-menopausal. So that is kind of what the journey looks like. Obviously, variations, but yeah.
Okay, so I mean, how on earth do we know where we are in all of this? I mean, are there any blood tests that can help us work all this out?
So, yeah, I get it. It's really, really confusing, and it's not really defined journey. You know, it's not like you're guaranteed to be going step by step following a textbook, and that's really confusing. For people who are not on any kind of contraception, yes, there could be some blood tests that can give you an idea where you're at. And probably FSH, or follicle stimulating hormone, is the one that will give you the most information. So FSH is basically your brain is reading how much estrogen there is around, reading the environment, and then sending a message to your ovaries, and pushing them to work. So basically, the higher your FSH is, the louder your brain is shouting at your ovaries. And generally, the closer you are to menopause, the louder your brain is shouting at your ovaries. So that high FSH or a rising FSH is an indicator that you are moving through the perimenopause towards menopause. Now, things are more complicated for some people. I think you come across this, right?
Well, exactly. So, for instance, you know, if you're on an oral contraceptive pill or have an IUD like Marina, I mean, how does that add into the mix?
Okay, so people who are on an oral contraceptive pill, they basically got synthetic estrogen and synthetic progesterone on board. When you stop your pill and get withdrawal bleed, that looks like a period. And there is no way knowing where you are on this journey, right? Because you've got an external source of both estrogen and progesterone, and that's taken, you know, that's taken over your hormonal cycle. For people who are on Mirena, what Mirena is providing is synthetic progesterone, but that, of course, is also influencing other things. So same thing, very difficult to know. For people who do have an IUD, that is a copper IUD. Copper IUD does not affect your hormones. So for those people, we can still rely on blood tests to give us some idea of where we are. So that is lie of the land. Yeah.
Okay, great. So, I mean, why is this such a long journey? I mean, what's happening to us in this kind of phase of life?
Right, here we are. So, all right. So this graph comes from Hormone Repair Manual written by Lara Bride, and I'll mention that resource a little bit later. But let's focus on the graph and what it shows. First of all, in pink is estrogen, and so it's showing your kind of fluctuations in your estrogen through your lifespan. And then in the blue is progesterone, and again, this is showing fluctuations in your progesterone through the lifespan. So if you focus on the middle bit where it says reproductive years, you can see that everything is pretty predictable. You know, yes, they're fluctuating, but they're fluctuating at a regular basis. You know what's going to happen. And then if you look at the teens and you have a look at the perimenopause, you will actually notice that there is similarity. So for those of you who have got, you know, daughters going through puberty while you're going through perimenopause, and you're both experiencing some horrendous hormonal storms, you're not imagining it, you are actually going up through similar things. But what I want you also to focus on if you're looking at the perimenopause is actually the shift in what happens to progesterone and what happens to estrogen. So you will see that progesterone is the one that starts declining first, right? So, and the estrogen is the one that becomes really quite erratic. So if you see in your reproductive years, the fluctuations in estrogen are actually relatively small. The fluctuations of estrogen in your perimenopause can be enormous. And that is, remember how I said this follicle stimulating hormone, your brain shouting at your ovaries. Well, sometimes ovaries will go, nah, not listening to you. And some months the ovaries go, all right. And they will produce huge amount of estrogen. And your symptoms can relate to that. Yeah.
Okay. Yeah. I love the way you explain things, Jasmina. It's always just really, it's great. So how do we actually, experience these changes in hormones? What does it do to our body? What are we kind of going to notice?
All right, that's a really good question. So let's have a look. So look, the crux of it is that the ratios of estrogen and progesterone are changing. So if, again, you look at the reproductive years, you will see that relatively you've got more progesterone on board than estrogen. And all of a sudden in the perimenopause, there is a shift in this stuff. So again, on this slide, you will see that you have less progesterone, you have more estrogen. And can you bear with me? I will actually take you through a bit of a science. So strap in. There will be a little table. All right. It will be a couple of minutes, but it will be worth it. All right. It will explain some of the things that you are experiencing. Okay. So here we are. So what you've got in this leftmost column, tissues that we're talking about. So, and they're related to how we experience symptoms. Then here you've got estrogen, and it's actually showing the effect that it usually has. You have progesterone, and it's showing the effect it usually has on these tissues. And then in the last column is really what we are interested in. So when you shift those ratios, when you have higher estrogen than progesterone, what it is that you will be experiencing. So first of all, at the uterus, estrogen says proliferate. Progesterone says stop. With this with this shift that you get, you'll get heavier periods. With the breast, it's a similar kind of thing. You will get proliferation of breast tissue, and that is breast tenderness, pain, so you can experience cyclical breast pain. Bone remodeling, again, something that we might touch on a little bit later, but even in the perimenopause, some women might actually start experiencing loss in bone density. Cardiovascular stuff. I won't kill you with science going through this, but enough to say that you are not imagining that these shifts in hormones have an effect on the regulation of the heart rhythm. So you might be experiencing palpitations. They have an effect on your lining of your blood vessels. So shifts in blood pressure can also result from shifts in hormones. And that, again, has a knock-on effect on some people experiencing the sweats and the migraines. Mental health, this is another really big topic. And the shifts here might be resulting in more anxiety, more depression, in disrupted sleep. And some of you who experience mental health issues, particularly with anxiety, depression in your adolescence, you might find that these are unwelcome visitors, like propping up their heads again and coming to visit you. Yeah.
Okay. So what does this mean in real life for women who are going through the perimenopause? It's just, there's so much going on. I didn't realize quite how much was going on, really.
All right, so it's another great question, Carolyn. So I actually asked a fairly large group of women, some were friends, some of them were patients, who are in this age group to tell me really what is it that they're experiencing. And look, here's a word cloud of what they have said. So basically, the bigger font, the more prominent the symptoms. And as you can see, some of the main symptoms that they're experiencing are related to weight gain, to disrupted sleep, to mood changes, and none of that is looking very happy, unfortunately. So
no, it really isn't. And you said that I think you said that perimenopause can last for about 10 years. I mean, that's way too long to sit with these symptoms.
So, and this is, part of the big part of the reason we're here really is to see what we can do about it. So here we are. We kind of have two levers, because I have said to you that we are experiencing changes in our estrogen levels, and we're also experiencing changes in our progesterone levels. So let's focus on these two levers. So first one is how we manage those estrogen swings. And the key here is improving the estrogen metabolism. So, if we say that ovaries will do what ovaries will do in perimenopause, the only thing that we can actually do is manage better estrogen once it's already there. So estrogen metabolism, estrogen detoxification, if you want to think about it, happens in several steps. So first step is it goes into the liver. There's two kinds of biochemical reactions that happen in the liver. The key outcome is that you make that estrogen molecule water soluble. Now, then you can pee it out or you can poo it out, right? So let's focus on what you can do for that liver phase of detoxification to improve it. So I've said cruciferous vegetables, because compounds in cruciferous vegetables upregulate those biochemical reactions in the liver that process estrogen. I've mentioned DIM. DIM is one of those compounds in cruciferous vegetables. You can take it as a supplement. B vitamins, particularly B2, B6, B12, are also important for these biochemical reactions. And so is calcium glucuronate. Remember, this comes as a supplement, and the focus here is on that glucuronate group, not on calcium, because the glucuronate group is like a little flag that makes estrogen water soluble. And then there are also supplements like NAC, N-acetylcysteine, and glutathione that are important antioxidants and protect liver health. Then dealumination, so hydration, obviously keeping well hydrated, keeping your bowels moving, looking after your gut, looking after your microbiome. Big topic. Maybe we'll come back and talk about this, but I'm just flagging it here. And then a way to get rid of toxins and also improve estrogen metabolism is also anything that makes you sweat. So exercise, sauna, whatever it takes, whatever you like that makes you sweat will help on this way.
Yeah. Okay. Just remind me an example of a cruciferous vegetable again, just so
cruciferous vegetables. Okay. Cauliflower, broccoli, broccolini. And for those of you with thyroid issues, don't eat them raw. This has happened. People have put them in the smoothies raw. Just steam them, cook them. Even if you have thyroid issues, once you have cooked them, you can absolutely eat them and they still maintain benefits in terms of estrogen metabolism. Yeah.
Thank you. And so what about progesterone?
All right. So progesterone. Look, first of all, I need to flag this. So whenever I'm talking about progesterone, I'm talking about body identical progesterone. I'm not talking about progestogen, which is a synthetic progesterone. The benefits that body identical progesterone has, synthetic progesterones do not have. We might touch on that later as well. So how do you get body identical progesterone? You can get them, the creams. I know some people go and get them on Amazon. Some people get them from a compounding chemist. But in my experience, this is not a brilliant idea. Often it's not enough. And in general, I don't advise people to get something that is sensitive just off Amazon. There is micronized progesterone. It's available in the capsules. It's available, it's a prescription medicine, but it's available in all pharmacies. And this is an absolutely brilliant way of getting body identical progesterone. And this form of progesterone is great also for managing anxiety, for helping with sleep, and it will make periods lighter. And then you can do things that make progesterone work better. Whether it is that you are taking this additional progesterone and you're giving it a helping hand, or if you're not taking additional progesterone, even if it is about making your own endogenous progesterone work better. So magnesium helps progesterone work on the central nervous system, again, improve mood and sleep. And magnesium glycinate is usually a very, very good option if this is your aim. Then taurine. Taurine is amino acid. It's usually found in animal-based food. Again, it helps synthesis of GABA, which is the calming neurotransmitter. And, you don't have to take it from animal-based foods. Often there'll be combinations of magnesium that also include taurine. So you can actually, if you're not eating animal-based foods, you can get it in a supplement form from elsewhere. Yeah.
Okay. I mean, what about Vitex? That's something that people often talk about.
Right. Vitex or Chase 3, it's very popular. It's been written about. It is a herb. I think that is why people tend to gravitate towards that as a, can I take something that's not a hormone? And Vitex, because of its mechanism of action, is actually very good for women in their 20s, in their 30s. But once you get to late 30s, definitely into 40s, Vitex will not do what you need it to do. Because remember, your ovaries, Vitex mechanism of action actually stimulates ovaries to produce more progesterone. And when we're in our 40s, ovaries just go, no, not really. So unfortunately, not a brilliant option for women 40 plus.
Okay, thank you. And so, I mean, if we can manage to calm the estrogen storm and get some more progesterone on board, I mean, what can we expect then? What happens then?
Alrighty. So one of the first things that people mention, and I think this is such an important cornerstone, is improved sleep. And once you get enough progesterone on board, you're more likely to get that deep, restful sleep. So, and this has a range of effects. If you're getting a decent sleep, you are less likely to be anxious, overwhelmed, tired, and it has very, very significant beneficial metabolic effects. And when I say metabolic effects, amongst that, I mean weight management, which is, most people think of. Mood, I've already mentioned, and then lighter periods, and for some women, those lighter periods are super important because literally those super heavy periods can keep them at home for, 2, 3, 4 days a month, and can result in them being chronically anemic and tired. So those lighter periods can be life-changing for some women.
Yeah, absolutely. So, I mean, does this mean that we don't have to worry too much about lifestyle factors?
No. But you know what? I did not want to put this up front. And the reason is that some women suffer such severe perimenopausal symptoms that when they're told, just eat better, stress less, and exercise, they just might want to kill you, because if that was that easy, they would have done it already.
Yeah.
So sometimes we need to come in with supplements or hormone support before women are able to implement lifestyle changes. Sometimes they're so exhausted that they need that little bit of help before they're able to do things for themselves. But lifestyle changes are super important. And, if you really want to get there, this is an essential part of the package. Sleep, super important. We all are sleep deprived for whatever reason, whether because we're stressed or we have so many things to do, or we're caught up with work. Alcohol is another enemy of sleep. So you can have 1 or 2. You might feel like it's helping you to relax. It might help you to get to sleep, but guess what? Actually disrupts deep sleep. So it's really not good for sleep quality. And diet-wise, we have this change of fuel. Again, I'll touch on this a little bit later. but we're not very good at handling carbs anymore. We can get these huge fluctuations in blood sugars that can result in these energy crashes. So we need to consider changing our diet. We certainly need to eat a rainbow, because remember, antioxidants protect the livers, they're great for aging, and then the cruciferous vegetables, because they help us manage our estrogen. Exercise, or putting in a little bit of cardio and putting a bit of sweat out helps that detox. But we also now have to think about weight and resistance training, because this is super important for maintaining our muscle mass and for maintaining our bone density. And then stress management, stress management is how do you say, just stress less. What do you experience in your practice? Tell us a little bit about that.
Yeah, whenever we encounter unpleasant physical or emotional symptoms, it's completely natural. Our natural response is to just get really tense, quite stressed. We want to avoid them at all costs. That's just normal. The problem is our mind typically goes into a full sort of problem-solving mode and looks for ways to fix what's going on and make things stop and make us feel better. And that problem-solving works great in the outside world, but it's really not so great when we're dealing with our inner world of physical and emotional experiences. And often the ways that we try to cope, the ways we try to make ourselves feel better, can actually cause more stress and just make symptoms worse. So you mentioned alcohol, just those kinds of things, really. And there's some really helpful psychological techniques in CBT that can help change our relationship to symptoms. There's a variety of coping skills that we can learn to help manage them. And it's really interesting to, sorry.
You know what, like you have such a unique set of skills, both with a health coaching, with a functional medicine background, and then those psychological support skills. I think it's a fantastic combination. It's finding that all in one place is quite rare, because sometimes we send people to a dietitian, sometimes we send them to a health coach, and then send them to a psychologist. So and that is one of the reasons I really, really love working with you.
Yeah, and my health coaching was fabulous, and then this additional kind of CBT hypnotherapy is just added, superpower to that, if you like. And when I work with someone, these are all the kind of things that we might want to look at and work on together. And just to say really that the way I like to work is really, really practical. It's not just spending time talking about the issues. You'll come away at the end of every session with something new to try and a plan of maybe 1, 2, 3 changes that you're going to experiment with, see how it works for you, just enable you just to get some momentum going, get some change happening so that you can really start to feel better and be more able to cope. So it's very practical, it's very hands-on, it's about change. So.
All right, when we're about change, let's have a look at the next one, because we've been focused on the perimenopause up to now. So let's have a look at the menopause. All right, so remember, the day you haven't had your period for 12 months, you're menopausal, and then after that, you are postmenopausal, right? So tell me.
No, I was just going to say, so let's get this back to real life. So once we've hit menopause, then so what are the main symptoms that women are going to experience then?
All right, so look, I have another word cloud to show you. And again, this comes from a bunch of friends, a bunch of patients, but also we have a lot of evidence from national surveys. So let's just have a look at what this looks like. So menopause, you see that fatigue and weight gain dominate in this word cloud. It's not as big, there aren't as many symptoms, but tired and weight gain are really, really big in this group. And then when we have a look at the national survey, we see that about 35% of women feel that menopause impacts their work life. And I'm really, really hoping that workplaces are changing and taking account of this. And then about 50% or more report that it impacts on their sex life. So big, big numbers there.
And I mean, does menopause also increase the risk of other medical conditions?
Yeah, it does. So let's have a look at them. All right. So weight was a big word there in the word cloud. When I say weight, I really mean metabolism, because you wouldn't be gaining weight if something wasn't changing in the background. And you will know, you would have met people who go, but I am not doing anything differently. I'm eating the same. I'm exercising the same. And look what's happening.
Yeah, every day.
Yeah. So there is a change of fuel, right? It's almost like you were running on a petrol engine and now you need a diesel engine. You just need a change of fuel. So as estrogen levels drop, and they really do in menopause, we become more insulin resistant, okay? And this means that we are no longer very good at handling carbohydrates. So we tend to run, we have more trouble managing our blood sugar levels. We need to produce more insulin to achieve the blood sugar management thing. And when you're running on high insulin, that is a signal for weight gain, and particularly the weight gain around the middle. And that visceral fat, that is a significant cardiovascular risk factor. We are also becoming more what I call anabolically resistant. So we are not as good at building muscle. In fact, we're starting to lose the muscle mass and we have to fight for it. So all of these are the reasons that we need to change the fuel, and we have increasing protein requirements. What we need to do is we need to work on our metabolic flexibility. In other words, we need to teach our body how to use fat as a fuel. And there's a number of tools in the toolbox. Again, not enough time in this session to go through all of them, but some of them are intermittent fasting. Again, brilliant tool, but not for everyone. Sometimes we need to actually have a look at people's blood work to decide whether that's the right tool for them. Exercise is always the right tool. You might need to find something that suits you and that you love doing and you'll keep going back to, but it will help you keep the muscle, and that muscle is a brilliant metabolic buffer that is so important for your health span. And then improving mitochondrial function, again, something we might be coming back to in future webinars. And there are lots of tips and tricks of how to do that. Amongst them is actually protecting our mitochondria from a whole heap of environmental toxins that we normally expose ourselves to. So.
And I mean, what about bone health?
That's a very good one. So, and it's actually quite typical. I didn't put it on the slides, and it's actually often something that's forgotten about. And people often don't realize what has happened to them until they get diagnosis of osteoporosis, and then they're devastated. But women tend to lose, on average, about 10% of their bone density in the first 5 years of menopause. That's huge. So if you're somebody who is light, somebody who has had eating disorder or a celiac disease undiagnosed for a long time, or any kind of inflammatory bowel disease or a bunch of inflammatory kind of conditions, or used steroids, now you are at a particular risk, because all of those things would have meant that you did not achieve your peak bone density. And so you don't have as good a base to start from. So for those people in particular, they should be getting their bone scans quite early on, so they know where they're starting from. Yeah.
Thank you. So could we also talk about maybe some more of the less talked about topics like sexual function?
Yeah, we can. And you know what? Often this is one of those, we're nearly done with a consult and you go, oh, but
can I just?
Shouldn't be. Right. So first of all, when we talk about sexual function, it is kind of divided into 3 subgroups. So one is libido. Do I feel like it? And quite honestly, if your relationship is not great, if you're tired and stressed, and if you're not sleeping, if you're overwhelmed, if you're anxious, if you're depressed, you're just not going to feel like it, right? It's just not a priority. Then lubrication gets its own little, space. And again, in menopause, because we don't have enough estrogen on board, we just don't get enough lubrication, we're just dry, the tissue atrophies, and it's painful. And again, if there's pain involved, then you're just not going to orgasm. Orgasm is all about pleasure, and if you're getting pain, you're not getting there. And orgasms might actually take longer because changes of those tissues mean they're no longer as sensitive as they were. So the stimulation you need more of, you need longer time to get there. So it's not that you are becoming dysfunctional, there are just changes, And if we understand them well, and there are things, again, that we can definitely do about all of those changes, there is no reason for our sex life to suffer. We can definitely do things to improve, we can do topical estrogen to prevent that vaginal atrophy. There are lubricants that are better than others for that sensitive kind of skin. You know what? There are really, really good vibrators that are aimed at women at this age group that can help. So they're all the conversations that we need to have, and we're not having.
Yeah, absolutely. I think it's something that women perhaps, feel less comfortable talking about out of all of the symptoms, and maybe just let it go and accept it. But it really doesn't have to be that way.
And then there's the urinary symptoms, and there is the frequency, there's the urgency, there's blood irritability. And, there's always a question like, have I got a UTI? Because this almost feels like one, or, but then the doctor tells me that no, there's no growth. I haven't actually got a UTI. And then there's people who genuinely are getting UTIs. So again, deprivation of estrogen will cause irritability of that urethra and the bladder. And people are genuinely getting UTIs again and again. Well, when you had lots of estrogen on board, the tissue was plump, urethra was held close, like that. So the bacteria just could not travel up to the bladder. Now, with the atrophy of those tissues in your perineum, urethra is not shut. It's a bit like that. So it can be a highway for the bacteria from your perineal region traveling into the bladder. And some people have noticed, after they have intercourse, they are at a much greater risk of getting urinary tract infection. Again, more bacteria moving around the area, the highway to the bladder is open, high risk of UTIs. So.
And what about all those joint pains and aches that commonly kind of
that is another really, really common one. And often people go like, I just feel like I'm on fire, but not the way I want. It's just everything is aching. So again, we're going back to that story of increased inflammatory tone. So insulin is one of the constantly high insulin is one of the drivers, pro-inflammatory drivers. And then if you also have gut problems, then it increases your inflammatory tone. But you know what? It can also increase your risk of autoimmunity. And we don't understand exactly what happens, but we know that women in their 40s, early 50s, they're the peak demographic for diagnosing autoimmune disorders. So those changes in the hormones definitely impact our immune system in a way that makes us prone to autoimmune diseases. Again, our gut can be the gateway that we really need to look after. Our gut is that barrier between the outside world, in other words, what you're eating, and our immune system that is looking for strangers. So gut health, really important in this age group. And then the changes in hormones also have an impact on tendons and ligaments, how flexible they are, how easily frayed they become. And with the prominence of female sport, female athletes, we are getting to understand a bit more about how estrogen and progesterone impact joint health. Again, something that props up in a menopause and perimenopause, and it's watch this space. It's super interesting area, but you're not imagining it. Changes in hormones do impact your joint health.
But I mean, how do we know if the symptoms that we're experiencing are menopause or something else? Kind of complicated to know.
You don't. That's the and you know, one of the things that I think is really, really important is that we do not look at a woman who's going through perimenopause and menopause and go, oh, you know, it's just your hormones. I think we really need to work hard for health system to respect symptoms that these women present with. So to me, it's super important to work up somebody who's presenting with some of those symptoms that we're mentioning. And only when we have had thorough medical workup and we're sure that it's not something else, we can go, it's most likely perimenopause or menopause symptoms. That is a diagnosis of exclusion. This is not a label that you stick on upfront.
Yeah, it's super important.
Yeah.
Okay, so let's say it is menopause. What's next?
Right. So one of the questions is to HRT or not. And often I'll go, I have a checklist and I go, well, let's be upfront and see who should not get HRT, just not. So these are women with personal history of breast cancer. We're not talking about family history, we're talking about personal history. Women with a personal history of uterine cancer, because these cancers tend to be estrogen driven and we do not want to add oil to the fire. And then you'll see I've got a little dotted line. And these conditions, so people are prone to clots, people have had heart attack or stroke, or people who have migraine with aura. So these tend to be, we used to exclude them, but now that we're understanding how HRT works and, you know, understanding the risk factors and so on, this is a bit negotiable. So this will really depend on an individual person. And then we've got chronic liver disease. Remember, I mentioned that we really need healthy liver to help us metabolize estrogen. So again, this is something for discussion. Let's see what the actual problem is, and then we'll see what we can do. And then who should definitely be on HRT? And these are the women who go through premature menopause, so before the age of 40, even before, if you ask me, before the age of 45, because that HRT, one of the things that will do, it will protect their bone density. And there's increasing evidence that might actually provide cardiovascular risk protection as well. You know, and people ask me, well, how do you decide? You know, this is a let's say I'm not completely excluded, but you know, how do I decide?
Yeah, and I suppose before we go through the ins and outs of HRT, is there anything else we can try? I mean, because some people are really worried about hormones.
Yeah. Look, I can understand. So, all the lifestyle stuff definitely applies. So I won't go over that, but all of those lifestyle things that we have mentioned, they all help manage menopausal symptoms. And then, look, what are we trying to do? So we're really trying to increase estrogen levels. And one of the ways you can try and do that is go for phytoestrogen. So they're estrogen-like compounds that are found in plants. So if you want to go for dietary option, so you can find phytoestrogens in soy, flaxseed, legumes. If you want to go through supplements, so Femula is a supplement that is available in most good pharmacies. It's actually going to give you a good dose of phytoestrogens. Now, another one that's quite popular or has been is black cohosh. Now, black cohosh is mainly being used in the context of managing hot flushes. I don't think it's worth it. black cohosh can cause abnormalities in liver function. It needs to be monitored. Its efficacy is not always great, so I don't think it's worth it. And then there are adrenal adaptogens, ashwagandha, rhodiola, licorice root, sometimes all three combined, and they can be used to manage the hot flushes, the mood issues, and sometimes even urinary symptoms. Again, it really can depend on the severity of the symptoms that you are experiencing, and not everybody responds in the same way to these supplements. It can be, if you're not desperate for something to work for your very severe symptoms, and immediately this can be a step that you go through.
Okay. So, I mean, going back to HRT, I mean, how do I decide? I mean, it's such an individual choice, isn't it?
Very much so. So it depends, what is it doing to your quality of life? Because for some people it's really, really clear cut. It just goes, well, I just can't live like this. That's it. So what, and some of the conditions that benefit from HRT, so hot flushes. That is almost a no-brainer. Almost everybody's hot flushes get better on HRT. Often there's an improvement in the sleep and hence mood. Also, there generally are improvements in genitourinary symptoms. There's definitely improvements in bone density. In fact, HRT is a first-line treatment for osteoporosis in postmenopausal women. Now, the three next dots, there's a little question over them. We think that in some contexts, HRT can lower cardiovascular risk. It's still contentious. Some people start HRT and they go, oh, I've gained weight. In some cases, when you just start HRT, you actually get a little bit more fluid retention until your body adjusts. But there is no evidence that HRT alone will cause you to gain or help you to lose weight. And then libido, again, it's very, very personal. Then the risk-wise, as I've mentioned, its main risk factors are estrogen-driven cancer, so it's breast, uterus, ovary, and for some people, clots.
I mean, how worried should we be about breast cancer risk? Because that's something that holds many women back. It's kind of the big one, isn't it, that we worry about?
Yep. And look, there is a brilliant infographic that I really like to share. I understand there is a lot of confusion in this space. There's been some flawed science, there's been some flawed interpretation of the science. But if we look at this picture, I think it really, takes people through quite clearly. So what we're looking at, and this is published by Women's Health Concern in the UK. So if we look at 1,000 women, and those women are aged between 50 and 59, and the reason we're looking at those because that's those hormone-driven cancers. So, and there are 23 cases of breast cancer per 1,000 women. Okay, so if we add what I call old-style HRT, so that is the one that uses synthetic progesterone, and I don't do that anymore. I always use body identical progesterone. We add additional 4 cases to that. If you're using estrogen only, and increasing evidence also suggests if you're using estrogen and body identical progesterone, you actually get 4 fewer cases, right? Add alcohol. So if you're somebody who has 2 drinks per day, which is many of us, that's 4 additional cases, right? So it's the same, you add the same risk as the old style HRT would.
With a glass of wine or 2 glasses of wine. Wow.
Yep. I mean, Australian glasses of wine are quite big. So by the time you have one of those glasses of wine, you probably had 2 standard drinks. Again, if your BMI is over 30, so if we're looking at women with BMI over 30, that's 24 additional cases. Okay. But then look at exercise. If you exercise just 30 minutes, 5 days a week, you get 7 fewer cases. So that's a risk reduction. So I think it's really, really important to take these numbers in before we just vilify HRT. And because of some misrepresentations, mainly through the media. Yeah.
Well, yeah, because if you just take the HRT out of context with not everything else that you've just, it sounds scary, but you add in everything else and it puts it into that context, doesn't it? So that's a super helpful graphic. Thank you. So, I mean, if we decide then, we'd like to try HRT, what should we do? How can we do it safely?
All right. So, first of all, there is what we call a safety window. So, and that safety window is 5 years post-menopause. Again, let's go to the definitions. You are menopausal 12 months after you have had your last period. So from that day when you get your menopause certificate, for the next 5 years, you are in that safety window. Why? Because it seems like you still have those estrogen receptors on board. Your body kind of knows how to handle estrogen, what to do with it. So we know that if you start your HRT, doesn't mean complete it. If you start your HRT within that window, your body knows how to handle it. How to choose HRT. Now, this is something that I'm really, really particular about. I always prescribe body identical estrogen. So it's the same molecule as your body would have made. And I always prescribe it as a topical. So it means it's a gel or a patch. The reason is if you take estrogen orally, there is 70% increased risk of blood clots. Just use it topically. And then the body identical progesterone has to be oral, right? And for those people who have uterus, you must take progesterone. It opposes the effect of estrogen that stimulates proliferation of endometrium and can lead to uterine cancer. So if you have uterus, you must take progesterone, and that progesterone will protect you. You do not want to take synthetic progesterone because it comes with increased risk of breast cancer, and it doesn't give you those benefits with sleep and mood that a body identical progesterone does. And then monitor. You might get actually a little bit of vaginal bleeding as you just start your HRT, but if you're already established on HRT and experiencing vaginal bleeding, that's not normal. We need to look at the reasons. We need to work you up. And the deal is you must have your mammograms, right? It's just participate in Australia. If you're aged 50 to 74, you're entitled to a free mammogram every 2 years. If you feel like mammogram is not enough and you want kind of the next level, breast tomosynthesis is also an option for you. And if you have a family history and particularly worried about it, if you're prepared to pay out of pocket, you can also access breast MRI. So there's lots of options, but whatever it is, you do need to do some kind of breast cancer screening.
Yeah, absolutely. I mean, what about testosterone? Is that something that we can and should use as well? I have heard a little bit about it, but I don't know a huge amount.
Yeah. So look, testosterone, again, in Australia, is a relatively new arrival to the HRT scene. Look, in our reproductive years, we have testosterone on board, and our testosterone does drop after menopause, and it's almost like, so estrogen drops, progesterone drops, we replace them, testosterone drops, we don't replace it. Why? Right? So we're starting to ask that question. And then in Australia, testosterone is available again as a cream. So it's used topically. And why we use it? Mainly at the moment, we use it for libido. There's evidence for women who have done everything else, haven't got there, having a bit of testosterone on board can help. And anecdotally with my patients, some of those who have tried testosterone can tell me like they just feel like they've got generally more oomph and more energy. But it's another thing that needs careful monitoring, because if you overshoot, you can have significant side effects, male pattern hair loss, oily skin, acne, hair where you don't want it. So it can be a really good tool, but let's monitor it to make sure that we are in that therapeutic window.
Yeah, thank you. And I mean, I know some women have experienced massive improvements in their quality of life once they've made that decision to start HRT and then they've been on it. And then they get to the point where they're actually really reluctant to come off it. I mean, what should we do? What are the kind of guidelines around that?
So a traditional answer to this question is just stop it. You know, if you've been on HRT for 7 to 10 years, you know, you should consider just stopping it. But we now, and you know what, even if you do that, it's not going to, the symptoms that you get are generally nowhere near as bad as initially when you're going through menopause. But there is increasing number of doctors, including myself, that we don't just stop it cold turkey, we wean it off, we reduce it. So, and again, anecdotally, it seems to be a bit of a more gentle transition. Look, and then there are people where they go, I just don't want to come off it. Do you meet people like that?
Yeah, absolutely. And I mean, I'm thinking of that word cloud again, and it was really not very happy. So things do get better then, is kind of what you're saying, yeah?
Yep, there is. Things do get better. So look, first of all, mood, mental health, it does improve. Apparently, the peak misery for women is in their late 40s. Most miserable people around are women aged about 47. Anyway, so that's the low point. So the mood definitely improves. Migraines, they usually resolve, but they can evolve into cardiac symptoms, unexplained cardiac symptoms, so almost like a cardiac migraines. They're not heart attacks, they're not dangerous, but they're those, you know, really puzzling symptoms. And this is something, again, that we might touch on later. There's a book that I'll recommend that deals with some of those issues. That's a really good read. Now, the weight, it tends to stabilize, but you have to fight for your muscle. So your muscle is your friend. If you manage to keep your muscle, build muscle, it will help you stay within the weight range that you feel comfortable with. Bones, you know what? We face declining bone density. But again, keep up your exercise. Make sure your vitamin D is in the optimal levels. Make sure that you've got enough calcium in your diet, or if it's not in your diet, in your supplements. So you do need to actually manage that. Cardiovascular risk, yes, it increases. You know, we know that as women hit menopause, our cardiovascular risks actually become bigger than those of men, which is not at all the case prior to menopause. But there is an enormous amount that we can do. Again, going back to those metabolic changes and managing that. And then the sexual function, actually things improve. You know, for whatever reason, maybe with this improved sleep, improved mood, and we learn to manage those genitourinary issues, sexual function tends to improve. Yeah.
I mean, I often wonder why we need to go through all of this living through after menopause. I mean, is it just a modern age thing, or does it have a bigger purpose and meaning?
You know what? I personally feel like that the whole process, it has its purpose and it can be empowering. You know, menopause, that can actually be an empowering stage of life. But as you know, I kind of like to look at things from a science perspective. And so I just want to take you through this little message that a science is sending, and it's coming from a research into orca whales. So orca whales, they're mammals, and their females actually go through menopause and they live up to 90 years.
Wow.
And so they're really the only animal species that we really know about that goes through this process that's similar to us. And so there was like, okay, so why that happens? So when they looked at these postmenopausal females, they really showed that they are the leaders of their pods. You know, there's wisdom, there's leadership, and their grand calves benefit. And even if it's not the grand calves, so having this postmenopausal, this grandmotherly female in the pod actually boosts survival chances of the entire pod, especially in the times of scarcity. So, you know, I kind of, that's how I see our role.
Yeah, that's a wonderful story. Love that. So I know you've usually got a few resources up your sleeve. So is there anything that you'd recommend as a bit of a compass on this journey?
Radio. So these are some of my favorite books. I've probably mentioned a couple of them. So one of them is called A Woman's Heart. And again, I haven't had enough time to talk you through this. But this book was written by Dr. Angela Maas. She is a cardiologist focused on female health. And it's a brilliant resource for anyone who's been experiencing palpitations, chest pains, difficult to manage blood pressure in the context of perimenopause and menopause. Honestly, you will not find a better resource. Read it before you go and see a cardiologist. The next one is a hormone repair manual. It's written by Lara Bride, and Lara is a naturopath focusing on female health. And this particular book is brilliant for perimenopause. It does have a good chapter on menopause, but you know, its focus really is perimenopause. And then the middle life, the middle pause by Marina Benjamin. Again, nothing to do. This one is not very sciencey. This one is looking at menopause from more kind of societal angle, but it's a brilliant read. I was at a tennis tournament in Bathurst. I borrowed the book, you know, had to go back to Sydney. I took the book with me and actually had to mail it back to the library because I just couldn't stop reading. So those are my, you know, they're quite different, but they're some of my favorites. So, you know, the other thing that I would like to say is I'm really hoping that what we've managed to do today is give people a little bit of guidance, give them a few tips, explain, you know, the journey of perimenopause and menopause, and that those books will be good guides. But for those people who need a little bit more, who need a little bit more help, you know where to find us. So I work with Evergreen Doctors. If you need a consult that is focused on a functional medicine approach, you can find me at Evergreen Doctors. And Carolyn, again, you have a brilliant and unique combination of skills in health coaching and psychological support skills. You're based in UK, but you also work with Australian clients, you know?
Yeah, absolutely. So, I mean, if anybody would like to arrange a conversation with me, then I work via Zoom, so online as well. We can arrange just a free initial chat to talk about the ways you might want to work together. And you can reach me at my website, which is on the slide there. So thank you.
All right. Well, thank you again for joining us on this journey through perimenopause and menopause. I hope we have managed to put some signposts for you and give you some tips that will make the journey easier for you. And if this is not enough, you know where to find us. Thank you again, and I hope we have made a difference for you.
Thank you, Jasmina.